Hello, good day and good evening, wherever you are in the world. Dear colleagues, dear friends, we start now another exciting e-forum, which is an international global webinar. And we have registered today more than 1,000 participants to this series. This is excellent. And probably because it is an interesting topic, not only for me, but also for the community. Diagnosis and treatment of refractory status epilepticus, including new onset refractory status epilepticus. This is a condition which is still enigmatic. Overall, refractory and super-refractory status epilepticus are not common conditions, fortunately, because we can treat status epilepticus quite effectively if we are early in the treatment course and if we use the right dose, and third, if we treat appropriately the underlying etiology and disorders. So I have the pleasure to introduce an excellent faculty, which I will do in a minute. But before I do that, please note at home that the panel is unable to respond to any questions referring to a specific case or to a specific patient. You may contact us wherever you are, but this is not the purpose of the webinar. It is an educational one. And I also want to wish to acknowledge the support of the whole e-forum series, which was an unrestricted educational grant from UCB and Jazz Pharmaceuticals. Please also note that you are, of course, indeed encouraged to put questions into the Q&A box at the bottom of the Zoom webinar, and this can be addressed during our discussion. And secondly, please also complete the short survey at the end of the e-forum, and we very much appreciate your input and your cooperation for that. These are the conflict of interest, the potential conflict of interest of our distinguished panel. And I introduce now the first speaker in our series. This is Professor Simona Lattanzi from the Department of Experimental and Clinical Medicine of the Marche University in Ancona. Dear Simona, it is a great pleasure that you are here with us and you hold this seminar on refractory status epilepticus. Please, Simona, the stage is yours.
Good day to everyone. Thank you so much, Eugen, for the kind introduction. Thank you, the organizer, to the invitation to take part of this e-forum. It is a great pleasure to start the discussion. And I will start with a very general overview about the refractory and super-refractory status epilepticus, coming from definition, incidence, etiologies, predictors, and outcome. So let's start from the very beginning, so with the definition. So what is refractory status epilepticus? So it is defined as a status epilepticus that persists despite administration of at least 2 parenteral medication, including 1 benzodiazepine. Of course, drugs need to be appropriately selected and dosed. And no specific duration is required to describe a status epilepticus as refractory, but just to lack of response to this medication. And what is the definition of super-refractory status epilepticus? So it is defined as a status persisting at least 24 hours after starting of anesthesia, either without interruption of status during treatment or a status which recurs while on treatment with the anesthetic regimen, or a status which recurs after withdrawal of at least 24 hours of anesthetic drugs, and so it requires anesthetic reintroduction. So what about the incidence? So we have quite robust data already to define which is the incidence of refractory and super refractory status in adults as well as in children. So this was a very nice retrospective population-based study performed in Salzburg, and all patients with status epilepticus were included, and hypoxic encephalopathy, of course, were in exclusion criteria. And the definition of status epilepticus follow the current ILAE diagnostic criteria. So overall, the incidence of status epilepticus among adults were 36 per 1,100 persons per year. And if you look at the different incidence of refractory and super refractory, so incidence of refractory was 7.2 per 100,000 adults per year, and the incidence of super refractories was much lower, 1.2. So overall, we can say that a refractory status epilepticus represent around 30% of the cases of status, and super refractory may represent from 3 to 4% of all episodes of status epilepticus in the adults. We have also data coming from the pediatric age. So this is again very nice retrospective study performed in German. And the overall incidence of status epilepticus in the pediatric age was estimated to be 17.6 per 100,000 per year, with some differences in refractory and super refractory. So refractory has an incidence of 3.9 and super refractory has an incidence of 2.3. So overall, the incidence of super refractory is less common overall in pediatric age, but the super refractory is even more common in the pediatric age than in the adult age. And more specifically, if you look at when the super refractory is more common in children, so we can see how it is usually to occur during the very early phase of the life. And almost half of all super refractory status epilepticus admission in children occur between 0 to 1 year old age. So let's move forward about the etiologies. So again, if you consider the classical distinction of the etiology according to the ILAE, and if you look at this publication looking at the 9-year course study, so we can see that if you distinguish refractory and non-refractory status epilepticus, considering as refractory, both refractory and super refractory, so the main result was that refractory status epilepticus was less commonly associated with remote symptomatic etiology, which was much more common in non-refractory patients. And if we split the refractory and the non-super refractory episodes, so and again, if you look at the different etiologies based on the ILAE definition, so again, we can see no huge differences in terms of the etiology categories between super refractory and refractories. And the main issue is that the most common etiology in both subgroups is acute symptomatic. However, I think it is also important to consider the different area of the world, because the etiologies may vary differently when we come from one continent to another, as shown very clearly by this prospective collection data of all patients with refractory status epilepticus who were admitted in an ICU setting and were treated with intravenous anesthetic. So more than 700 episodes were included from more than 50 countries all around the world. And if you look at the results, so the main result was that overall history of the epilepsy was identified in 38% of the episodes, while the remaining had no any clear history of the epilepsy. And if you look at the overall study population, so the most common etiologies was unknown in more than 1/4 of the population. And among those episodes with the established etiology, so the most common was vascular, including stroke for 14.5% of the cases, followed by acute encephalitis and anti-seizure medication reduction or withdrawal in patients with epilepsy. So now it is time for the third question for you, and would like to ask you, what is, in your opinion, the most commonly identified etiology of refractory status epilepticus in Europe? And also a very similar question, what is the most commonly identified etiology of refractory status epilepticus, but this time in Asia? So the options include vascular, infectious, traumatic, and metabolic. So please vote. The options are the same, and the difference is related to the continent, Europe or Asia. Okay, so we have the answer. So the most common answer was vascular, 51%, when we talk about the etiology of refractory status in Europe. And when we talk about Asia, the most common answer was 68% was infectious. And I think it is absolutely correct. And so we have some data coming again from the same publication that I showed you before, that the etiology may vary differently across the different area of the world. And as you answer very finely, vascular etiologies are more frequent in Europe than in Asia, while infectious etiologies are much more common in Asia than in other areas of the world. And specifically also acute encephalitis was much more commonly in Asia than in Europe or in the Americas, as you can see here. And there was also trend toward higher incidence of traumatic etiologies in Europe and in the Americas, while it is very purely represented in Asia. So we know that there are a lot of etiologies that may cause status epilepticus, and the question is whether all etiologies are the same in terms not only of incidence, but also in terms of prognosis. And usually we believe that acute symptomatic causes are associated with a poorer outcome compared to remote causes. But I think that this very broad definition can be only partially indicative and reliable of the predictive power of the diagnostic classification. So for example, if you take in account 3 different causes within the spectrum of the acute symptomatic etiologies, as for example, low level of ASM in patients with epilepsy, or alcohol-related causes, or cerebrovascular diseases has stroke. So we can see that the mortality for these 3 different acute symptomatic etiologies is really different. And for example, patients with the low ASM levels are associated with a very better outcome compared, for example, to stroke due to status due to acute stroke. So based on this perspective, I think that we can try to think to a different framework to classify the acute known condition of status epilepticus. And this is our proposal to distinguish acute symptomatic etiologies of status epilepticus into 4 different categories. The first one is called acute triggering factors in the epilepsy, so which include, for example, withdrawal or low levels or inappropriate prescription of anti-seizure medication in people with pre-existing epilepsy, or, for example, sleep deprivation in patients with epilepsy. The second group is the one of acute primary CNS insult and pathology, for example, stroke, active CNS infection of head trauma. The third group is acute secondary CNS brain pathology, including metabolic disturbances or systemic infection. And the fourth group is the drug or alcohol intoxication and withdrawal. So why it can be important to use a different framework for acute symptomatic etiologies? Because if you look at the outcome, so this condition may have a very different outcome in terms, for example, or poor clinical outcome at discharge, as well as in-hospital mortality. So if you look at the rate of poor outcome into these 4 different groups, so we can see very huge differences, and patients with acute primary and acute secondary CNS pathology usually have a much poorer outcome with higher rate of poor clinical outcome discharge and higher rate of mortality. So I think that heterogeneity exists within the spectrum of acute symptomatic causes, and maybe a more granular etiological subcategory classification may inform us much more better about the clinical outcome. So within the context of etiology and definition, I will just to give you a very brief overview about new onset refractory status epilepticus, or NORSE. This is just a clinical presentation and not a specific diagnosis in a patient without active epilepsy, without any pre-existing relevant neurological disorder, without any clear acute or active structural, toxic, or metabolic cause, who present with a new onset of refractory status epilepticus. And usually these patients have super refractory status epilepticus. And what is FIRES, or febrile infection-related epilepsy syndrome? So this is just a subcategory of NORSE with the prior febrile infection starting between 2 weeks and 24 hours before the onset of refractory status epilepticus has the key point necessary to put the diagnosis of FIRES. Fever can be present or not at the onset of status epilepticus, and although this condition is much more common in children, however, this definition is valid for all age subgroups. So if you look at the etiologies into this specific category of status, so in NORSE, in adults and children, so the most important issue is that around 0.5% of the cases of NORSE remain without any clear etiology. So these are called as cryptogenic NORSE. Among those patients where an etiology can be identified, so in adults, the most common etiology is autoimmune encephalitis, either non-paraneoplastic or paraneoplastic, while infections represent the most common etiology of NORSE in pediatric age, when, again, we can identify an underlying causes. So the next point here is about the predictors. So which are the predictors of refractory and super refractory status epilepticus? So if you look into the literature, we can identify a lot of factors that have been associated with increased risk of refractoriness, which include the etiology, which include the semiology, the age, the severity based on the test score. Some biomarkers has, for example, albumin, some EEG patterns, but however, I think that so far we have no any reliable system to predict who will develop refractory and super refractory status epilepticus. So maybe can we ask to the artificial intelligence to give us some aid, some assistance? So let's do it. So we try to identify the predictors of progression to refractory status epilepticus through a machine learning technique, and we use the decision tree analysis as the specific statistical approach within the machine learning analysis. So we use a refractory status epilepticus as the dependent variable, and all clinical variables associated with the refractory status in the univariate analysis were considered as potential explanatory variables. And so this is the decision tree that we obtained. So first of all, around 1/3 of the patients evolve into refractory status epilepticus, and the most important variable able to discriminate those patients who will develop versus those who will not develop refractory status epilepticus was the impairment of consciousness before treatment. Other variables include acute symptomatic hypoxic etiology and periodic EEG patterns or spontaneous burst oppression, and also followed by non-convulsive status epilepticus, auto-setting onset of the status, and remote symptomatic etiology. So if we bring together all these parameters, we are able to identify different clusters of patients with a very different risk of refractory status epilepticus. So the most benign clusters is represented by those patients with retained consciousness before treatment, without the severe EEG pattern, with an out-of-hospital onset, and with remote symptomatic etiology. So in this subgroup of patients, the risk of refractory status is 1.5%. On the other hand, the worst scenario is represented by those patients with impaired consciousness before treatment and acute symptomatic hypoxic etiology. So in this case, more than 90% of the patients will develop refractory status epilepticus. So if you look at the overall performance of this model, so the success in classification in the patients is quite high, roughly 80%, but the models is much more reliable to predict those patients not progressing to refractory status epilepticus compared to the prediction of those patients who evolve to refractory status epilepticus. And we did a very similar exercise to try to predict the progression to super refractory status epilepticus. Again, data come from the Modena cohorts. Overall, the evolution to super refractory occurred in 16% of the patients, and again, some different parameters allow us to distinguish different subgroups. So the most reliable variable is acute symptomatic hypoxic etiology, followed by age and non-convulsive semiology, as well as periodic EEG pattern. So again, we can identify several patterns. So the patients with other than acute symptomatic hypoxic etiologies and non-convulsive usually have very low risk to progress to super-refractory, while on the other side, patients with acute symptomatic etiologies and younger age, which was younger than 16 years in this study, were at higher risk of super-refractory. So again, the overall success of the model was quite high, but again, we are much more able to predict those patients not progressing to super-refractory, while the ability to predict those patients evolving to super-refractory remain quite low. So let's move forward and talk about the outcomes of the patients with the refractory or super-refractory status epilepticus. So overall, if we look at the outcome in patients with status epilepticus, for example, in terms of in-hospital mortality or poor functional outcome at discharge, so we can see that a lot of variables associated with the refractoriness, including the treatment with the anesthetics, the duration of drug-induced coma, the number and duration of second-line anesthetics, and many others, are associated with increased risk of poor outcome. And so, for example, if we look at this very recent publication, the risk of death during hospitalization was higher than 37% in patients with refractory status epilepticus, and the risk of functional decline at discharge was really high, more than 74%. And if you look at some predictors of poor functional outcome or in-hospital mortality, so for example, a higher burden of comorbidities or a lower Glasgow Coma Scale at the time of the starting of anesthesia, are associated with increased risk of poor outcome. However, again, I think that we can try to distinguish different subgroups of patients within the category of refractory status epilepticus. So in other words, the question is whether if any patients with refractory status epilepticus is the same in terms of outcome or not. So again, we try to distinguish into the refractory status epilepticus patients two different groups. One group is called as refractory status epilepticus responsive to successive treatment with the anti-seizure medication. So this is the group of the patients who failed the treatment with the benzodiazepines and one second-line treatment with ASM, but which respond to next attempt with the anti-seizure medication. And the second group within the refractory status epilepticus was represented by the refractory status epilepticus responsive to anesthetic drugs. So in this case, we included patients who did not respond to any anti-seizure medication, but then they did respond to anesthetic medication. And so if we look at the outcome, for example, in terms of in-hospital mortality in these two different subgroups of the patients, so we can identify some differences. And the refractory status epilepticus responsive to general anesthesia was associated to a higher risk of in-hospital mortality compared to refractory status epilepticus who responded to the anti-seizure medication. And in the bars, you can see the rate of death during hospitalization for the different subgroups, responsive, super-refractory status epilepticus, and in between the two subgroups of refractory status epilepticus that we introduced. So again, I think that there is some degree within the refractoriness, and this degree of refractoriness maybe should be considered to explain better the spectrum of disease severity and heterogeneity of outcome in patients with status epilepticus, and specifically with refractory status. What about the outcome in patients with super-refractory status epilepticus? So again, we have evidence from this very nice systematic review and meta-analysis, which included all studies reporting adult patients with non-anostic super-refractory status epilepticus. So mortality was quite high, and it was associated with the duration of a super-refractory. The longer was the duration, the higher was the risk of mortality, but there was a plateau reached around after 1 month of treatment. And about also the probability of cessation of super-refractory status epilepticus. So there was a relationship with the treatment duration. So a longer treatment duration increased the likelihood of cessation of the status epilepticus, but this did not translate in any reduction in mortality, but increased as it was related to an increased risk of moderate to severe disability. And so overall, the disability was quite high, and more than 1/4 of the patients had disability at the discharge. When we think to the outcomes, we can also try to consider, for example, the risk of recurrence of status epilepticus for these patients. So it is the risk of another episode of status epilepticus. And of course, etiology is maybe the most important predictors, but also refractoriness is significantly associated. So super refractory and refractory status epilepticus increase the risk of recurrence, and not only increase the risk of recurrence, but also increase the risk of early recurrence within 6 months in this study, for example, coming from the Modena court. Another outcome of interest is for sure the risk of the epilepsy after status epilepticus. Again, we have evidence that some parameter can be associated with the risk of the epilepsy. One is the duration of the status epilepticus. So the longer is the duration, the higher is the risk of epilepsy after status epilepticus. These are results coming from the Spanish group. And this association was true only for acute symptomatic causes. And the other predictors of epilepsy is, of course, the etiology. And again, if we focus on the acute symptomatic causes, the risk of epilepsy is much, much more higher in patients with acute primary CNS damage compared to patients with status due to acute secondary CNS or acute toxic causes. However, when we think to the outcomes, we also have to go behind seizures and think to long-term outcome. So in this very nice retrospective medical study, 19 patients with super refractory status epilepticus were included, and any patients were scanned with an initial MRI within 2 weeks from the onset of the status, and the second MRI within 6 months after the resolution of the super refractory status epilepticus. So if you look at compare the MRI in these patients. So the first message was that atrophy developed in all patients with super refractory status epilepticus, and the median change in ventricular brain ratio was around 23%. And there was a clear relationship between the duration of the anesthesia and the loss in brain volume. So the longer was the duration of treatment, and the higher was the risk to develop a significant atrophy in the brain. So to conclude, about the definition, we can say that for sure, refractory and super refractory status epilepticus may represent potentially life-threatening medical emergency condition. Refractory and super refractory are not so common, but are not so negligible, and they are common to be seen in clinical practice. Etiologies may be different across the different patients, but sure it remains one of the major determinants of outcome. There are a lot of predictors of refractoriness, but so far we are not any validating scoring system to predict in clinical practice who will develop refractoriness. And about the outcomes, so this condition may be associated with significant mortality and morbidity, not only on the short term, but also over the long run. And thank you so much for your attention.
Well, thank you, Simona. This was an excellent overview, very clear talk, and we have time for a few short questions, and we have 2 questions, and I think also 3 questions in the chat, which are related to the etiology. Well, first of all, what about the etiology in Africa? Do we have data on that? What are the most common ones?
So we have also some data, of course, less than for other continents, but I think that, again, I think that infectious etiologies may represent a quite important cause of status epilepticus, and also in Africa as well. And I think that also some preventive measure should be adopted to try to minimize as much as possible the risk of status in these patients in Africa, in children also, not only in adults.
Yes, I think in the survey you presented, these were infections most commonly, but if you look at the subtypes, for instance, I'm aware of a study in Malawi where the children, malaria was number 1, and the non-malaria causes of febrile status, it was then encephalitis and meningitis. So very strong difference in the etiology, which is of course important when we look at the outcomes and the treatments. So I think that were very relevant questions. And when you briefly comment to the time frame which you had in your definition, is it the same for adults and children?
Yes, I think it was the same, really, yeah.
Okay. And the other question is, as Alia said, a nice presentation. Would you start permanent anti-seizure medicines in cryptogenic NORSE if etiology is vascular with anti-seizure medicine treatment, or would you have a permanent treatment after refractory status? So the question is, does it make sense to make long-term treatment when you have a high relapse rate?
Yes, I think it is a very important question. I think it is really challenging so far because we have no so robust data to provide us a strong guidance of our clinical practice. So for sure, cryptogenic NORSE, I think that anti-seizure medication should be continued for a quite long period. Of course, there are also evidence that some element, for example, the EEG, during the follow-up, if we can have some persistent epileptic form abnormalities during the follow-up EEG, or if there is some signal of lesion in, for example, in the MRI. So these are other variables that we can put together to try to describe how best approach whether to continue or not. But I think that generally speaking, it is quite challenging to stop the treatment with anti-seizure medication in this specific scenario. So, for example, in some NORSE due to autoimmune encephalitis, we are building up with some evidence that, for example, the duration of the status, the MRI pattern, as well as the antibody status may all guide us our decision in clinical practice. But we have to individualize as much as possible, I think, our approach.
Well, we get so many questions that this is fantastic, but unfortunately we have to move on for the other talks, and I hope that we have some time at the end. So Simona, please stay with us, and I'm going to announce now the next speaker, which is Aurelie Hanin from Paris, and she's working at the Paris Brain Institute, which is associated to the famous Salpêtrière, where 201 years ago, Calmet made the first clinical description of status epilepticus in the modern times. Well, there were descriptions before, but he is responsible for the term which we still use, état de mal status epilepticus. So, Aurelie, you are going to talk about the role of biological biomarkers for refractory status epilepticus. This is a hot field in research of status. Please, the stage is yours, Aurelie.
Thank you so much. Thanks for the introduction and for inviting me to participate to this e-forum. This is a great pleasure to discuss today about biological biomarkers for refractory status epilepticus. Biomarkers have been defined decades ago by an NIH working group as a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacologic responses to a therapeutic intervention. And from this definition, we can extrapolate multiple objectives for biomarkers in refractory status epilepticus. First, a biomarker may be used to help in the diagnosis of status epilepticus, and this is notably true for non-convulsive status epilepticus when EEG is not quickly available everywhere. Then, when you have diagnosed a status epilepticus and the patient is refractory, you may use biomarkers to help monitoring the evolution of the patient in the ICU. We all know that when a patient has a refractory status epilepticus and is treated with anesthetic drugs, we need to have a good balance between a too important sedation that will increase the risk of complication in the ICU and a not enough important sedation that will increase the risk of going to a super-refractory status or prolonged super-refractory status epilepticus. Then, biological biomarker may be used to help managing both anti-seizure medication and anesthetics in order to reach a personalized medicine approach. Biological biomarker can also be used to help identify an etiology for the status epilepticus, and this is notably the case for autoimmune encephalitis when you are looking for autoantibodies. And they can be used to help initiate targeted immunotherapies in that case. Also, biomarker can be used to help in the prognosis status of the status epilepticus, meaning that you want to assess the risk of mortality at short term, or to predict the chance of recovery if the patient is discharged with some sequelae, and what will be the functional outcome after several months or years. If we look on PubMed and search for biological biomarkers and status epilepticus, we will find above 300 references and more than 30 biomarkers discussed. However, currently, there is no biological biomarker that is used in clinical practice everywhere. And this is mainly due to the fact that currently no biomarker have all the criteria for an ideal biological biomarker. So what are the most important criteria? First of all, the biomarker needs to have a differential expression, meaning that it has to be present in patients and it has to be absent or minimal in control. However, in clinical practice, it almost never happens. So we need to manage the both parameters, sensitivity and specificity. If you look at the graph on the left, if you want to have a 100% sensitivity, you will have the risk to have false positive patients. However, if you want to identify only disease patients with a good specificity, you have the risk to have false negative patients. So to balance both criteria, you need to use the Eugen index and determine the optimal threshold for the biomarker. Another important criteria is the accessibility of the marker. It has to be detectable in common body fluids, CSF, blood, urine, and saliva. And it could be better if it's detectable in blood or urine or saliva that are more easily accessible. Also, from an analytical perspective, the biomarker needs to be stable, simple to measure, and compatible with standard clinical biochemistry labs. And if you want to use it for the diagnosis of the status, given this is an emergency situation, you have to have a rapid turnaround time. Also, it's important to have a good reproducibility with result consistent across measurements and across laboratories. And if you want to define a biomarker for a disease, it has to match the underlying pathophysiology of the disease or its consequences to have a biological relevance. And last but not least, it's important to take into account the pre-analytical and analytical condition for the biomarker. You need to respect the good tube. Is it for serum? Is it for plasma? You need to respect the transport condition, at room temperature, in ice, in dry ice, the centrifugation delay and time, and to take into account the duration of the analysis. For example, if it takes 8 hours to process the samples, you can't use it as a diagnosis biomarker. So in the next step of the presentation, I will discuss mainly about the biological relevance. In 2015, the definition of the status epilepticus has been revised for a condition which can have long-term consequences after the time point T2, including neuronal death, neuronal injury, and alteration of neuronal networks. These three parameters are consequences of refractory status epilepticus. But we have many other consequences for refractory status epilepticus. Some occurs very quickly. This is the case of the acidosis. You may find neuronal injury after a few days, axonal injury slightly later on. You can also have the activation of the astroglial cells, a neuroinflammation, all leading to neuronal excitability. And for each of these consequences, multiple biomarkers have been discussed in the literature. For acidosis, the most commonly known is the lactate, measured in the CSF. For neuronal injury, we will discuss later on about the potential of neuronal specific enolas. For axonal injuries, there are some interest for tau, protein phospho-tau, and the neurofilaments. And for astroglial injury, the most extensively studied is the S100 beta protein. Also, the cytokines are extensively evaluated both in patient and in animal model for status epilepticus. I will focus on three specific hallmarks: the neuronal injury, axonal injury, and neuroinflammation. For the neuronal injury, the most extensively studied biomarker is the neuron-specific enolas, or NSE. NSE is a glycolytic enzyme that catalyzes the conversion of the 2-phosphodiglycerate to phosphoenol pyruvate. We have multiple isoforms of the enolase, but the NSE is primarily expressed by neurons. And when we measured elevated level of NSE in the serum, it means that the biomarker has crossed the blood-brain barrier, and therefore it gave us information about the blood-brain barrier permeability. The half-life of NSE is about 24 hours, and therefore this is totally possible to measure the biomarker daily in order to follow the evolution over time. However, for analytical and pre-analytical parameters, it's important to take into account the hemolysis because serum levels may be falsely elevated in the case of hemolysis. NSE has been extensively studied in status epilepticus, and the story started in the 90s when the team of Di Giorgio, Rabinovich, and Curial have reported elevated levels of NSE in the serum and in the CSF, and in all major subtypes of status epilepticus. They have also described that the levels correlated with the status epilepticus duration and outcomes, and that most patients reach a peak in the serum within the first 24 hours after status epilepticus onset. Despite the interest of these findings to help in diagnosis identifying patients with status epilepticus, the studies were conducted in 2 small patient groups in order to be used in clinical practice. So we have restarted working on this biomarker in our team in Paris in the 2020s, and we demonstrated that indeed the serum NSE levels are increased in patients in status epilepticus compared to patients with isolated seizures. However, the discrimination power to diagnose the status epilepticus was lower compared to other biomarkers like the protein S100 beta. And this is acknowledged by an area under the curve of 0.62, which is lower than for S100 beta protein at 0.75 or for progranulin at 0.76. And this AUC 0.62 is clearly not enough to be used in clinical practice. However, we also highlighted that the serum NSE levels and its evolution over time correlated with an EEG severity score able to predict the risk of seizure recurrence within the next 24 hours. It was the case in a patient with autoimmune encephalitis. This is a graph at the top where you can see the NSE level represented by the red curve and the EEG score represented by a black curve with higher EEG score representing a higher risk for seizure recurrence. And it was also the case for a patient with status epilepticus due to a metabolic disorder with the graph at the bottom. We also highlighted that serum NSE were able to predict poor discharge and long-term outcome, making NSE a monitoring and prognosis biomarker. The second hallmark I would like to discuss is the axonal injury with the growing evidence and interest for neurofilaments. Neurofilaments are proteins that maintain the structure of the axonal cytoskeleton, and they are essential for the optimal propagation speed of electrical impulses. When the axon is injured, the neurofilament will be released, and it's possible to measure them in the CSF and at a lower concentration in the blood. We have 3 major subtypes of neurofilament: light, NFL, medium, NFM, and heavy, NFH. Of course, neurofilaments are not specific for status epilepticus. They have been discussed in many other neurological disorders, including ALS, Parkinson's disease, frontotemporal dementia, and Alzheimer's disease. It's important also to note that the levels of NFL increase around with the age and until around 60 years old, and therefore the normal values need to be adjusted according to the age of the patient. And also, we can't measure with the current analytical tools we have the NFH in the serum. So the story of neurofilament in status epilepticus is more recent than for NSE. It started in 2012 when a team reported elevated CSF NFH levels for status epilepticus versus single seizures. About 10 years later, another team reported elevated serum NFL in electrographic status epilepticus. And even more recently, the team of Stefano Melletti in Italy described elevated serum NFL levels in patients with status epilepticus, with higher levels in the case of longer status epilepticus of longer duration, but without differences between convulsive and non-convulsive status, suggesting that even a non-convulsive status epilepticus is associated with an axonal injury. Because they also found a correlation between the levels of NFL and the 30-day worsening of the patients, NFL can be highlighted as a prognosis biomarker. Regarding inflammations, we have a lot of discussion to know if inflammation may be a cause of status epilepticus or if inflammation is slowly a consequence of the seizures. So I will try today to explain you that actually both may happen. So regarding the cause, if we look at the classification of the seizures, we have different etiologies that are strongly associated with inflammation. This is the case of infectious and immune condition. And it's therefore not surprising, as explained by Simona, that the most frequent etiologies for NORSE are autoimmune and paraneoplastic encephalitis in adults and infectious encephalitis in children. However, in all the other etiologies, inflammation may happen. And this is due to the fact that after seizures, all the cells in the brain can produce inflammatory components, and that could be released into the blood-brain barrier and cross to go in the blood. It was also described that these inflammatory molecules may increase the neuronal excitability and participate to persistent seizures and even refractory status. The role of inflammation has been extensively described in patients with NORSE because we had the hypothesis that NORSE is a disorder of immunity leading to exacerbated inflammation. In 2023, we conducted a study exploring a 12 cytokine panel in 61 patients with NORSE that have been compared for the first time to other patients with refractory status epilepticus from a known cause. We found in patients with cryptogenic NORSE, so without an etiology identified, that there was an increase in innate immunity-related serum cytokine levels, suggesting that innate immunity can contribute to the pathophysiology of NORSE. We also observed that increased cytokine levels correlated with worse functional outcomes at short and long term, suggesting that inflammation can also contribute to the consequences of the status epilepticus. Following the publication of these results, we have been contacted by many other centers in the world to analyze cytokine profiles. Therefore, we have developed two cytokine platforms, one at Yale in the United States and one in Paris, for timely analysis of serum and CSF cytokine levels. Since the launch of the platforms, we have measured 580 serum samples and 236 CSF samples from patients with NORSE. This allows us to identify three inflammatory cytokine profiles. The first one is the most severe ones. It's present with increased levels of innate immunity-related pro-inflammatory cytokines, interleukin-6, interleukin-8, GCSF, and CCL2. It's mainly seen in the serum and sometimes also in the CSF. In contrast, other patients may present only with elevated level of serum T cells-related cytokine, interleukin-17A, interleukin-12, TNF-alpha, with normal level of interleukin-6 and interleukin-8. And in some other patients, despite a similar clinical presentation, we have a normal cytokine profiles. This is important because according to the cytokine profile, you may guide the appropriate use of targeted immunotherapies, making cytokine therapeutic biomarker. We have continued this work to further explore the mechanisms underlying these different clusters. With Martin Guillemot, who is a PhD student in Paris, we have measured 96 cytokines in 62 patients with cryptogenic NORSE, revealing three major clusters of patients, cluster A, cluster B, and cluster C. By a protein pathway analysis, we identified that patients with cluster A, who were mostly older than other patients, had no specific inflammation, and therefore they might not benefit from targeted immunotherapies. In contrast, patients in cluster B had elevated levels of innate immunity cytokines, and we can find leukocyte recruitments, migration, chemotaxis, and degranulation. So all the parameters linked to the innate immunity. Therefore, they might benefit from a treatment with anakinra, tocilizumab, or anti-TNF alpha therapies. Patients in cluster C were the youngest one, and they have dysregulated autoimmunity processes involving T-cell development and function and the JAK-STAT pathways. They may benefit from treatment with rituximab, cyclophosphamide, or anti-JAK-STAT therapies. The strength of this approach is that it's possible to identify the suspecting underlying mechanism for new patients only by measuring cytokines and plotting the cytokine to the circle. For example, for this patient, the cytokine profile was quite similar to those in these subclusters belonging to cluster C, dysregulated autoimmunity processes. We can therefore use them again as therapeutic biomarker. So to conclude, many biomarkers have been discussed for refractory status epilepticus, but none is currently used in clinical practice. To change this, we need to have new study with larger cohort size and more homogeneous cohort size. It's also important to take advantage of the new analytical methods that allow us to detect lower concentration. And this is thanks to this new analytical method that we are now able to measure the neurofilament light level in the serum. Also, we need to keep in mind that the biomarker selection need to match clinical objective, and obviously it will not be the same biomarker for diagnosis status and identify an etiology. So far, the inflammatory biomarkers are the closest to clinical implementation. They may reflect an underlying etiology and have the potential to stratify patients, for example, for therapeutic trial. This is notably the case in NORSE, where we identified innate immune dysregulation as potential mechanism for cryptogenic NORSE pathophysiology and consequences, with the cytokine having an importance to guide immunotherapy. However, rapid results are needed in this emergency situation, and for this, there is a key role for biorepositories in order to have an equity in access to care. I will conclude by thanking all the people involved in this project, both at the Pitié-Salpêtrière Hospital in Paris and the NORSE team at Yale University. Thanks for your attention.
Thank you so much. This was a fantastic talk and exciting how the things moved quickly. You had a very nice aspect. You told us about the pathophysiology, the role, and then you said, what is the story of the thing going on, which you of the biomarker which you have under observation. We had a few questions in the chat, and we have a few minutes. One was, of course, related to treatment with anakinra and with rituximab, etc. And then you answered that there are clusters of cytokines or inflammatory patterns which suggest to give either one or the other treatment, CD20 depleting drugs like rituximab, or whether you give anakinra or tocilizumab acting on the interleukin-1 and interleukin-6 receptor. How can we implement that in clinical practice, or is it already too early? Is it now too early? Where do you think we should go further, especially in areas where we don't have these cytokine level measurements?
This is a very important question, actually, and it's reached the question of equity access to care, because in some places like Europe or United States, when cytokine may be measured quite easily, it is now possible to guide the use of immunotherapy according to the profile. And we started to do this in our places in Paris to provide some information to clinicians about the cytokine profile and discuss with them the best approach. Regarding the countries that cannot currently measure the cytokines, I think the most important things is to give them the opportunity to participate in large cohorts research program where they can only collect the samples and ship them to other places where cytokine can be measured. And this is what we are currently doing with the 2 biorepositories in Paris and the one at Yale for patients with NORSE. And all centers can just contact us, norse@yale.edu, and we will provide help to measure this profile and answer that question regarding immunotherapy.
Okay, so there are a lot of questions, and one was related, very practical. which one could be used for a treatment monitor, especially for non-convulsive status epilepticus?
I would say that the one that seems to be the more important to reflect the neuronal injury for non-convulsive status epilepticus may be the neuron-specific NOLAs, because this marker increased very fast after status epilepticus onset. And also we have observed some modification over time because thanks to the half-life of 24 hours, if you measure it daily, you can follow the evolution of the patients. So I would say that this one is very important to follow the evolution of your patient and maybe adjust the therapeutics.
Does it hold true for every etiology? Because there's one question. Yassin Abdallah asks whether vascular injury may be a confounder for especially NSE.
Yeah, it's totally true. According to the baseline of NSE in a patient will differ according to the etiology, but the evolution over time might be the same. And for example, we observe that patients with autoimmune encephalitis often have lower levels of NSE compared to patients with acute TBI or vascular disorders. And this is important because the initial levels may differ, but the evolution and the increase from one day to another day will be the same.
Okay. One other tricky question is that NSE is used as a negative prognostic marker in hypoxic ischemic brain injury. Based on what you said, we could expect that NSE is increased due to status, especially in anoxic brain injury. This would lead to a false negative view on the prognosis and maybe also change the treatment decision.
Yeah, it's actually a very difficult situation. And I think this highlights one very important thing is currently we can't judge the prognosis just with one biomarker. And we need to take into account multiple other things. The biological biomarker, maybe yes, but also the clinical practice, the response to treatment, the MRI, and everything needs to be managed together before going to an outcome prognosis decision.
Okay. Do we have any biomarker which are specific for etiologies such as NMDA encephalitis, aside from the antibody, which can be negative in some instances?
There have been some studies exploring some cytokine in specific time of encephalitis and reporting that maybe one cytokine can be specific in one encephalitis. I think currently we are far away of this, also because we know that all seizure will induce inflammation, so we will have a mix. So I will not say that we have so far specific biomarkers for one etiology, and maybe we may have biomarkers for a group of etiology, but unfortunately not for a specific one so far.
Okay, and how long does it take to, well, the question is, how long does it take to analyze the serum inflammatory biomarkers, and is it possible to order that through your lab?
That's totally possible to order that from a lab. So according to where the centers are, if they are nearest to Europe, it will be done in Paris. If they are nearest to the US, it will be done in the US. So you can contact us again. The email address is norse@yale.edu. And the delay to do that, it's like the most important time is to receive the biospecimens. So it can take a few days, a few weeks, according to some centers. We try to have it below a week. And after to measure it, it's like for the day of measurement, it's 8 hours to measure a cytokine profile, and above, you can say 5 or 6 hours to analyze it. So it's a long day, but we try to do it as often as necessary to provide timely results.
Yeah, and there was one comment or remark, how do you balance then? You have to make upfront treatment, and then you wait for the biomarker, and then you change your treatment.
Yes.
That's what I assume. But are there also biomarkers for predicting epilepsy? So Simona told us a lot about the clinical side in prediction of post-status epilepsy. Do we have biomarkers for that too?
There are not a lot of literature about that. It was described initially that when you have a more important neuronal injury or axonal injury, you may have more higher risk to develop post-NORSE epilepsy. for example, or post-status epilepsy in general. So in that case, NFL may be a good biomarker. But so far, we don't have strong arguments to know if a biomarker measuring the first days of the status may predict what will happen for the epilepsy in months or years after the end of the status.
Yeah, so thank you. I mean, you see that we have almost hundreds of questions, not the questions coming in, and we are a little bit short in time to answer all that. So please stay tuned. Aurelie, thank you very much for the fantastic talk, and we hopefully have some time at the end. And I now call the next speaker. It's Professor Larry Hirsch from the Yale University. And I think, Larry, you will address a very important topic, and this is related to the treatment of refractory, super refractory status epilepticus. So please come to your talk, and the slides should move now.
Thank you so much for the intro, for this opportunity, and I've greatly enjoyed the prior talks and learned a lot already. Okay, yes, now it's moving. So I'll be talking about treatment of status epilepticus, including a bit of the NORSE at the end, and mostly on refractory status. So I'll make a few conclusions related to all status at the end. So a lot of what we do is extrapolating from non-refractory status, because that's where the real class 1 studies are and the really reliable good evidence. So for example, this is the classic, fairly recent established status epilepticus treatment trial that looked at benzo refractory status epilepticus and showed very clearly that levetiracetam, fosphenytoin, and valproate were all very equal in efficacy. Graphically, I think shows even more how equal they were, and tolerability was also equal. So all of those are good options. I do make the point whenever talking about refractory status that it's crucial to think about non-convulsive or purely electrographic status, as the majority of prolonged refractory status becomes non-convulsive. And without some access to EEG, whether intermittent or continuous, it's going to be hard to identify or treat it. Just some classic examples of this in the VA cooperative status epilepticus study. 20% of patients were still seizing on EEG after all movement stopped. And then in the Di Lorenzo paper, they did 24 hours of EEG and showed 14% were continuously seizing, and just about half of patients had intermittent seizures with 24 hours of monitoring. There's other systematic reviews that have looked at EEG monitoring in critically ill patients. This one was about 20,000 patients and found that non-convulsive seizures were found in about 18% of these critically ill patients. About half of those qualified as status epilepticus. And they did point out in this study that the prolonged monitoring was 3 times as likely to detect seizures compared to a routine EEG. So I like to use this. Clinical seizures will be obvious at the bedside, but it turns out that about 3/4 of seizures in critically ill patients are non-convulsive. In fact, about 3/4 of patients have purely non-convulsive seizures. So you need your EEG tech to identify them. Okay, so why do we care about those non-convulsive seizures and ongoing non-convulsive status epilepticus? Well, all of these acute physiologic effects have been documented with non-convulsive seizures. I won't go through all of them, but it's really neuronal stress, neuronal injury, some swelling, increased blood flow, peri-injury depolarizations, and all of these can really exacerbate worse outcome in people with acute brain injury. If you look at medium and long-term effects of non-convulsive seizures, it's been shown that there's increased mass effect after intracerebral hemorrhage. There's increased hippocampal atrophy on MRI after traumatic brain injury, and it's on the same side that their non-convulsive seizures were. If you look at longer outcome, there's worse functional outcome, quality of life, and new onset epilepsy in children with status epilepticus. That was not seen with isolated seizures, but it was seen with status epilepticus. And in the adults, the first study to show that very clearly was in subarachnoid hemorrhage, where the seizure burden was associated with outcome, but it has since been shown in almost every etiology that non-convulsive status is independently associated with worse outcome. This is one of the classic papers that in pediatric patients in the pediatric intensive care unit that showed that if your maximum hourly seizure burden was greater than 20%, that virtually all of those children had worsening and neurologic decline at the time of discharge. And that has been incorporated into the definition of non-convulsive status epilepticus, which is now if there's more than 20% of any hour of recording shows that the EEG occupies more than 20% of that time, then that counts as non-convulsive status. This is the one of the best large adult studies looking at seizure burden, and that's another major point I like to make, that it's not just having seizures, yes or no, it's really the amount of seizures and the duration of seizures. So this one found that at 3 months, seizure burden was associated with disability, mortality, and cognition. And this is from that paper. It shows that the hours of non-convulsive seizures were associated with worse functional outcome and with a gradually dropping cognitive score. And there was no particular cutoff here. It was just the more hours of seizures, the worse the cognition. The other thing that's been realized recently that it's not just seizures, but even periodic discharges, especially when they get to 2 per second or faster, are associated with neuronal injury. So this study looked at with invasive monitors in the brain, showed that when periodic discharges reached 2.5 per second, that there was a significant drop in brain tissue oxygen, so showing additional neuronal injury. So they concluded from that study, at least in comatose patients with subarachnoid hemorrhage, the metabolic demand can be reached by increasing blood flow up to about 2 per second periodic discharges, but not faster than that. So this recognition of the harms of prolonged seizures or high seizure burden and the potential harms of periodic discharges led to studies like this, which looked at automated detection of highly epileptiform patterns. So this included seizures, but that was a very small minority of the patterns found here. Most of them were periodic discharges or lateralized rhythmic delta. And they looked at a variety of measures of the burden of this epileptiform activity. And they found that the peak 12-hour burden was the best predictor of outcome with a very strong association and a dose-dependent manner. And they were also able to look at subgroups, and this was done in almost 2,000 patients with an automated system. And they found with acute brain injury, with a cardiac arrest and hypoxic ischemic encephalopathy, these are patients with epilepsy who came in with acute status, and those with a systemic medical illness and no acute brain injury. So in all of these subgroups, the peak epileptiform activity burden correlated with the probability of poor outcome. So I use this far side cartoon. So this scorpion represents non-convulsive seizures, especially a high seizure burden or status epilepticus. And I now add a high burden of periodic discharges that are 2 hertz or faster. And we know if you use a coma-inducing drip, it will get rid of that virtually all the time and decrease the brain injury from that. But obviously those drips have putting someone into coma for a prolonged time has complications as well. So it is a tricky balance sometimes on how aggressive to be. All right, so what do we have for prospective randomized trial of refractory status epilepticus or non-convulsive status epilepticus? Well, unfortunately, we really don't have any good prospective randomized trials to answer these questions. So we're left extrapolating from other sources such as the established status epilepticus or just uncontrolled series. The one class 1 trial that was prospective and randomized for non-convulsive seizures was this one. It's called the TRENDS trial. And this looked at non-convulsive seizures, but this was not status epilepticus. In fact, that was an exclusion. And it compared fosphenytoin to lacosamide using EEG as the outcome. And the bottom line was lacosamide was a little better, was proven to be non-inferior to fosphenytoin, but not superior in this relatively small trial. So the conclusions and the tolerability was exactly equal. So the conclusions from this trial was that lacosamide was non-inferior to fosphenytoin for controlling refractory non-convulsive seizures, and that they're equally tolerable. We did publish a review on managing non-convulsive seizures and non-convulsive status. The real key point is to try and diagnose and treat quickly, because we know it'll be much more effective if you get to it early. So the exact same treatment will work if you diagnose non-convulsive status in the first few hours, but it won't work if it takes you a couple days. Seizure burden definitely matters. And I do like to make the point where if you tried 5 medicines and a full load of them didn't do anything, you should really stop those rather than just keep adding on, or patients end up on way too many medications. In general principles for non-convulsive status on the right, we'll give a slightly lower initial load than we do for convulsive status on the left. And then you just watch their response, especially on EEG, and you give additional doses if you need to. These are the intravenous medications that we commonly use. Whatever's available in your area should be fine. We do like to use different mechanisms in the refractory cases. So rather than using several sodium channel blockers or just multiple GABA agonists, we try and mix those. So here's your GABA agonist, sodium channel blockers. So we usually will have an SV2A modulator. Levetiracetam is really the most commonly used drug now for established status epilepticus. And often now we're adding on either an AMPA or NMDA blocker. So that'd be perampanel, which is not available intravenously, but ketamine is. In general, we will try a few of these medications before moving on to potentially going to anesthesia. But if a patient is in coma or stupor and still has a high seizure burden, that's when we go to our anesthetic drips. In our place, we tend to use midazolam first, and more, if that doesn't do it alone, we add on ketamine for the theoretical synergy between them. But if they're not in coma or stupor, or the seizure burden is low, we'll stay away from the coma-inducing meds and just add on some of these oral agents through a nasogastric tube. And again, seizure burden is important. It's not necessary to remove every seizure, or sometimes you'll never get people off of their treatment or off of their drips if you try and do that. These are other options for refractory status epilepticus. I really won't have time to go into all of them. They've all been reported to help in some cases. A couple of them have had large, good trials that failed. So hypothermia was one of those. Allopregnanolone study for super refractory status was also a negative study. But all of these are reasonable in select cases, and specifically for NORSE and FIRES, we'll talk about them in a minute, the immunomodulation. I would like to point out one other issue, and that's the pyridoxine levels. So there was this paper about a decade ago that didn't get too much attention, but showed that almost all patients with status epilepticus were deficient in pyridoxine or vitamin B6. And that's a cofactor for glutamic acid decarboxylase, which turns your glutamate into GABA. So if you're deficient in that, you can imagine you'll have too much glutamate, not enough GABA, and that is not a good thing when you're having trouble with refractory seizures. So in conjunction with Cleo Rubinos at University of North Carolina, we looked at this in a large group with some controls. It was almost 300 patients. And remarkably, using a pretty strict cutoff, 80% of the status epilepticus patients were deficient, almost as many as in that prior study, compared to only 20% of outpatients. Other hospitalized patients still had a pretty high rate, but not as high as status epilepticus. So because of this, and until there's more study, we have incorporated giving pyridoxine and sending levels in our refractory status epilepticus patients. I'll just put, this is our protocol at Yale for treating status epilepticus. Starts with lorazepam as always, then a lot of options. The 3 ESET drugs, levetiracetam, valproate, or fosphenytoin are next. I do point out a couple other things. If there's no IV already in place, it's perfectly fine to use intranasal, buccal, or intramuscular medication. Almost always midazolam for that. I do think it's important to send troponin levels. Patients cannot complain that their chest hurts while they're in refractory status, and its convulsive status particularly is a massive stress test. The other thing I point out is when you're using anesthetic drips, you need to do boluses until the seizures stop, and then you can put them on maintenance. But you need to keep bolusing until it stops. The drip itself will take way too long to stop it. So you give bolus till it stops, and then you put them on your maintenance drip. Okay, now a few words about NORSE and FIRES. Fortunately, Simona and Aurelie already covered a lot of this, so I can go fairly quickly. I'll stick primarily to treatment recommendations. So this one came from international consensus recommendations led by Ronnie Wickstrom. So in the first couple of days, you manage status epilepticus like you would with any other etiology. And then zooming in on this, by 3 days, we recommend initiating first-line immunotherapy. So it's usually steroids with or without IVIG. And then by 1 week, it's recommended to give the ketogenic diet if you have that available, particularly in kids, but also in adults. And also at 1 week to initiate second-line immunotherapy. So if it's antibody-mediated like NMDA, then rituximab is felt to be the agent of choice. But for cryptogenic NORSE, it's recommended to give either anakinra or tocilizumab at 1 week. And I'll tell you about a trial we're about to start that will randomize between these two at day 7 for cryptogenic NORSE. So what do we know about those agents? Well, Aurelie published this review. And unfortunately, the numbers are very small so far in the literature on how many patients with NORSE have been treated with these agents. But they seem to work, at least in an uncontrolled fashion, in more than half the time. But unfortunately, long-term outcomes are still quite poor. There are some adverse effects, especially to anakinra and tocilizumab. Intrathecal dexamethasone, no one's actually reported a problem yet. And post-NORSE epilepsy is still very high, so there's a long way to go. As far as the intrathecal dexamethasone, on top of those 8 patients, we just published from our study in neurocritical care a series of 12 patients. 10 of them were reported to have seizure improvement. Actually, one of them only got 1 dose, so it's really 10 out of 11 patients. And they were able to come off of their anesthetic infusions a median of 5 days after the last dose. But I'll point out that the last dose might be close to 2 weeks after the first dose, so it's still can be a long time. It's not instant response. And serial cytokines have shown variable findings so far, not a complete rapid drop in all the cytokines that we would like to see. Outcomes, a lot of the patients do poorly. Still about 20-25% don't survive, including in our ongoing series. And many have neurologic disability, behavioral issues, and refractory epilepsy. However, there is a substantial minority that have very good outcomes in the long term, despite very severe initial illness, including sometimes months in coma. We've set up an institute and a website for this that has extensive resources both for clinicians, families, patients, and researchers. Some of the things we offer are assistance with acute cases. We have a family registry. We have 2 studies going on. One is a multi-center study where you need to be one of the studies that has IRB approval. But for anybody else in the world, we have an open biorepository where we can accept samples. And as you heard from Aurelie, we'll run either in Paris or in the US, we will run cytokines, the rapid panel for you after we get it. That is purely research. Just put in mind that's not something you can order clinically, but we can consent to patients directly from Yale, and you do not need local IRB approval in most cases. So when we get samples, these are all the things we run. So we do autoantibodies, we do whole genome sequencing, cytokines, transcriptomics, and this is all in collaboration, both with the Paris group, with UCSF, with Michael Wilson, and with the Mayo Clinic with Chuck Howe's lab. And I mentioned briefly this trial. We just recently were awarded funding to complete this study. We're calling it Combat NORSE for comparison between anakinra and tocilizumab for NORSE. That's ChatGPT's logo for me, not our official logo. So this is going to be a 5-year, 33-center international trial looking at functional outcome at 12 months as the primary outcome measure, with an ambitious large number of patients. And it will be basically at day 7, just telling you whether to use anakinra or tocilizumab. And we will have extensive outcome data in all kinds to hopefully answer this and learn a lot more about NORSE and FIRES. So conclusions on treating status epilepticus. These are things we do know. Benzos are better than placebo on the way to the hospital. We learned that long ago. Lorazepam is more effective than phenytoin. IM midazolam is more effective than IV lorazepam if you do not already have an IV in place. These are all the classic status epilepticus trials. For benzo refractory status, these 3 agents are equal. You will do better if you can treat earlier. In post-anoxicoma, the Telstar trial showed that treating generalized periodic discharges aggressively is unlikely to be a benefit. However, if you have refractory electrographic status epilepticus without other signs of poor prognosis, so these are definite seizures, not periodic discharges, aggressive treatment does seem to be beneficial, and in this one series, almost half of cases had good functional outcome in that subgroup. Things we do not know is where intranasal fits in, where brivaracetam and lacosamide fit in, where ketamine fits in, but we're about to learn more about that from the KeySet trial that's just beginning. So that's a ketamine for established status epilepticus. We don't yet have clear neuroprotective agents. Maybe if you can't stop the seizures, at least you could stop the brain injury. We don't yet know if serial administration or cocktails are the way to go. When we do treat with anesthesia, the endpoint is not clear. In general, recommendations are to go to seizure control if you have continuous EEG monitoring. If you do not, then burst suppression is a good estimate of the dose you need for that. Conclusions on treating convulsive status. Again, diagnose and treat early. Have a written protocol. Again, use your IM if you do not have IV access. Don't waste time. Give the loading boluses until seizures stop before you start your maintenance. And don't forget about non-convulsive seizures. For treating non-convulsive status, the key thing is to remember them and diagnose them early. Remember that seizure burden is really important, not necessarily treating every single seizure. And to diagnose early, consider any method of getting a rapid EEG that you can find. And there's more and more of those just starting to emerge. And we treat similarly to convulsive status, but you have time to try lower doses first. And lastly, the conclusions on NORSE and FIRES. NORSE is a clinical presentation, not a specific diagnosis. It's likely post-infectious immune in many cases. Early immunotherapy seems to be beneficial. By day 3, start something, and by day 7, your second-line immunotherapy. Prognosticating is difficult, but if imaging is okay and other organs are surviving, many of the survivors actually do very well in the long term. There's still significant mortality and morbidity, and we have extensive ongoing research. Please reach out to us with cases. And if you want to use our samples to do some research, let us know as well. We have a simple application process for that. And lastly, I will thank my NORSE team at Yale and elsewhere listed here. And Thank you very much.
Thank you very much, Larry. This was a fantastic talk, and your summary was also very useful in dividing what we know and what we don't know. This was almost a closure of the whole webinar. We have a whole series of questions, and I now suggest to bring back to the camera Simona and Aurelie, and we make a little, if you agree, of course, we make a little crossfire talk, and we have, let's say, 6 minutes, and we have 12 answers. So I just say the question and the name, and I beg you for a very short answer. So number 1 goes to Larry, role of plasma exchange in NORSE.
There's certainly cases that show it's effective, and if it's antibody mediated, definitely can have some role. I do worry that it takes too long and delays later treatment. So if you do use it, don't delay your other treatments.
Okay, so one question to Aurelie. For patients with NORSE, since autoimmune antibody panels take 2 to 3 weeks to return, how do we decide anti-20 treatments versus inhibitors in a timely manner?
May depend on the presentation. If it's something clearly related to autoimmune encephalitis, I would like to say like rituximab therapy. If it's a presentation with like mild fever or other symptoms in the past days, maybe more with an anakinra.
Great. How can we distinguish post-epileptic sedation with non-convulsive status epilepticus?
Who's that one to?
Simona.
Oh, you're muted.
Simona.
Sorry, yes, I think that EEG can be a very reliable method and way to distinguish between the different scenarios.
Yeah,
Great.
I'll add that unfortunately there's no great way without EEG. Facial twitching has been a hint, certainly if you see nystagmus, eye deviation, those kinds of things. But unfortunately, it's most patients, there's no way to know without the EEG.
Great. So Aurelie, what is your opinion about the future of evaluating biomarkers, NFL and NSE by spectroscopy, magnetic resonance imaging?
Good question. So far, I think it has not been extensively studied because we are getting new method and new technique and immunoassays that demonstrated good quality. So I will not say what will be the future in spectroscopy, but could be an option for sure.
Thank you. Next question to Larry. What do we do specifically if we induce a drip? As you said, we have a bolus. How long should we wait? 1 minute, 2 minutes?
Yeah, usually just a few minutes is enough to see if the bolus is going to work. And once you're at that stage, it's okay to give slightly more than you need. I think aborting on continuous status is the key there. So.
Great, thank you. And Tobias Loddenkemper asks, Larry, how do you best differentiate epileptic encephalopathy and non-convulsive status epilepticus, in particular in children? Treatments and treatment response may occur in both.
Yeah, it's very difficult. If you're fortunate enough to have their baseline EEG, that is a key because the EEG should look different than their baseline one. And other than that, you really have to go by clinical and whether they're different than their baseline clinical status. But yeah, it can be extremely difficult. Some children look like they're in status epilepticus their whole life. So.
Great. One question to Simona. When to taper anti-seizure medicines and to shift to oral medication in NORSE?
So I think that once we have obtained the cessation of status, we may switch to oral drugs. I think the biggest challenge is to decide or not to continue the medication after the discharge and for how long we have to do that.
Great. Aurelie, in resource-limited setup, NSE is not available. Alternatives, what are the alternatives and what is feasible as a next option?
We started to evaluate the CBC, so the complete blood count that is available almost like everywhere and easily. So we have demonstrated in NORSE quite good performance to predict the outcome. So maybe it can be another option there.
Thank you so much. How long, Larry, should we maintain suppression with intravenous anesthetic drugs before we taper them?
Yeah, no great answer. We usually do 24 hours of seizure control. Some people have done shorter for the first trial and longer if it's your second, third, or fourth trial. But there's no great data giving you a clear answer on that, though. I can point out that if you're in burst suppression, you still have highly epileptiform bursts. There's a couple studies that have shown that you're unlikely to be able to come off at that point.
Okay, now we have a question to Simona and to Larry. What is the role of phenobarbital in acute status epilepticus, high-dose phenobarbital in FIRES?
Yes, I don't know we have any specific data about FIRES and NORSE. I think that we can extrapolate data that we have already from super refractory status epilepticus. So it may have a role when other treatments have failed, I think.
Great, thank you. Larry, last answer?
Oh, same question? Yeah, for people who are having trouble getting off of barbiturate, high-dose phenobarbital, including pushing to levels that are 100, 200, very high, can be very effective, and sometimes they can wake up even at what seems like extremely high levels.
Excellent. So the last question goes to all the three speakers. Should we aim with anesthetic drugs for burst suppression or should we aim for seizure control? Aurelie?
I would say seizure control, but I'm not an expert, so I would say the two MDs in the panel would be better to answer this question.
Good. Simona?
Yes, I think so. Seizure cessation may be already a good endpoint, but depending also if you have the continuous EEG monitoring available or not.
Good. Larry?
I agree exactly. Seizure control if you have the monitoring.
Yes, I agree too. Thank you so much. That was fantastic. And I don't want to start a wrap up because, Larry, you summarized what we know and what we don't know. But if you have one slogan, early treatment seems to be better than late treatment in any case. Time is brain. Early diagnosis is important, and sometimes it's not so easy, especially when we try to distinguish subtypes of refractory status epilepticus. As Simona pointed out, they are not all the same. And what is a major concern, and this is based on our questions which we had in the chat, there seems to be a huge gap in diagnosis and in treatment globally. And I think we have to address that specifically. I thank you all for being here and giving so wonderful talks. And it is very important for you at home to give us a feedback when you leave the e-forum. We really appreciate your cooperation. If you have some specific questions, please write via the ILAE homepage and we will try to get that into the right channel. Stay tuned. We will have other very interesting topics, and the e-forum will be available on demand in approximately 1 week. You can listen carefully, and then maybe some of your answers are already answered when you heard it twice. Thank you so much. The next forum will be Role of Digital Technologies in the Management of Epilepsy. Save the date. Good morning, good evening, and good night. Thank you so much. Bye-bye.